let's go through some basic stuff. The way I like to think and the way I like to talk and teach is to build up from basics. So I'm going to start well below all of your knowledge level, and we're going to just keep building and layering and layering and layering, and we'll go from there. Does everyone have mass? Okay, so whoever has mass, you can take the strings off. You can just rip them off. And while I'm chatting, what I'd like you to do is take your mask and fold a corner in like so, and then tape it.
Oh, tape.
If you can. So that it looks like that. And then fold the other side again. So now it looks like that. And then do the same thing with the other three. And then I want you to connect them. Like so. Can anyone not see that? So we're going to take two of them together, fold it on each other, and tape the corner. And we're going to do the same thing on your last one. So you should have something like that at the end. And I promise you it's worth your while if everyone does this, because this is the cheapest and by far the best aortic valve model you'll ever be able to make. And once you have all three, we're going to close it together and make a triangle. Does everyone have that?
I'm going for tape, 1 sec.
So you should have something like this. Okay. I don't like my view right now because I only see. Okay, good enough. Okay, so let's go with some basics now. The aortic valve is, let's start with someone. Jinfeng, we'll start with you since you're a rookie. Let's get you on the screen. What is the primary, we're going to start with basic physiology, and Chris will attest to this, okay? I'm nowhere near the smartest person or anesthetist you've ever met. Chris, fair to say?
You may be actually one of the worst.
Okay, perfect. So I'm proof that you can do well in this field by being average at best. And Chris can also attest to this. I practice two basic principles when I practice cardiac anesthesia. I practice concept one is stupidity avoidance. I try not to do anything grossly stupid. And the second thing that I practice is homicide prevention. I try hard not to kill people. So if I can avoid and identify things that kill people, I don't do those, and then my patients tend to live. So I think of things at a very, very, very basic level. So Jinfeng, you're up. The aortic valve is a purposeful structure in the heart. And what is its purpose for? What does it do?
To prevent backflow of blood into the heart.
So it prevents backflow into the heart. So when the left ventricle contracts, we get a stroke volume. And when that stroke volume ejects, the pressure in the ventricle increases. When the pressure in the ventricle increases at the beginning of systole, what happens to the mitral valve?
It closes.
Closes. The pressure on the inside of the ventricle then increases as systole happens. And what happens to the relative pressure in the ventricle when compared to the ascending aorta?
It's higher.
It's higher. So what happens to the aortic valve?
It opens up.
It opens. And then during diastole, when diastole happens, the pressure in the ascending aorta becomes greater or less than the ventricle?
Greater.
Greater. What happens to the valve?
It closes.
It closes. Okay. What, in an ideal situation, a normal situation, when should you have flow through the aortic valve and what direction should it go in?
So there should only be flow during systole, and it's from the ventricle to the ascending aorta.
Correct. So the cardiovascular system, the circulatory system is circular. And in theory, we should only have unidirectional forward flow. So aortic arterial system takes it out, venous system back, and so on. So we have a unidirectional valve that allows for stroke volume to exit. We know that stroke volume times heart rate is cardiac output. We know that cardiac output times SVR is blood pressure. So a stroke volume times a certain rate, along with the pressure of the ascending aorta, gives us a pressure and gives us a P high. Correct? Now, flow in the body will go from P high to P low, and it will dissipate. So we know that our venous system, what's our right atrial pressure?
7.
Sure, 5. 3 to 8, doesn't matter. Let's say 5. What's our arterial pressure?
Mean of 65.
Okay, sure, 75, 80, doesn't matter. 75 to 5 is a delta of 70, and we have flow, so things will move. Okay? Now, whoever's done, we'll go on to Serena. No, not Serena. We'll go to Milka next. Milka, have you done an anesthetic for an aortic valve replacement?
Yes, yes.
Okay. When you've done an aortic valve assessment, what have you predominantly focused on?
Well, first the valve structure. Assess how many leaflets the valve has. What's the mechanism of the disease, depending if it's stenosis or insufficiency. Ascending aorta too, and to see if the pathology is not on the valve, might be on the ascending aorta.
Okay.
Gradient.
Yeah. Okay. Yeah, go ahead. And let's say some associated structures around it. Okay, so you've done all the checklist. At the end of the day, Celine, since you're on the screen, oh, you haven't done this yet. Juan, you're next. At the end of the day, of all the things you can assess, almost exclusively, if someone is coming to the OR for an aortic valve replacement, let's say for calcified aortic stenosis, that diagnosis and all the structures that Milka just talked about were already identified. So we're not making new diagnosis of anatomy here or physiology. So if we take all of that aside and we assume that we know all of that beforehand, what is the real measurement that a surgeon only cares about? If they look over from the other side of the drapes and they ask you, what can you tell me about the valve? What's really the only variable that they care about? If that.
Did you ask me? Sorry.
Yeah, one.
Okay.
Sorry.
Maybe they'd be interested in the gradient.
Nope. They already know that. If the gradient is low, let's say the gradient was 80, so let's say the peak was 80, indicating you need a replacement, and you go into the OR and you measure 20, which is not an indication for surgery. Are they going to stop the surgery?
No, they're not.
No. Okay, so what do they really, if they ask for anything, what is it that they want?
Not sure. Nothing comes to my head right now.
They
Well,
want heparin.
if they're putting a prosthesis in, that's a bit of a hint. What do they want to know with regard to a prosthesis?
The aortic valve annulus size.
The annulus size. So why do they want to know the annulus size?
To see which size of the prosthesis they can put in, and
Exactly.
and if
Exactly.
they enlarge the root or something.
Exactly. You really just want the aortic valve diameter or the annulus diameter. Okay, Celine, if you go back to embryology, and I don't want to know embryology, we have our LVOT, or left ventricular outflow tract, which is a cylinder. Okay, a cylinder is just a tube. And then we have an aortic valve sitting inside the tube. And then we have an ascending aorta, which is the same cylinder. And that goes up to the arch and then down to the descending. Okay? What is the approximate diameter of the aorta? You're muted. Sorry.
Between 2 and 3 centimeters?
Let's call it simple. I'm a simple guy. We'll call it 2.
3. 2.
2. So if the diameter is 2, what is the radius?
Is 1.
1. If the radius is 1, what's the area?
Is point. Is the radius
What's the area? What's the area of a circle if the radius is 1?
is 4 is elevated to 3, sorry.
3.14?
3.14. So pi r squared. So pi is 3.14. Remember, I'm a very simple guy. Don't look for anything complicated. I barely passed high school. So if the area is 3.14, let's call it 3 to make it easy. If an aortic valve, which opens during systole and closes during diastole, is going to be the most effective, ideally, we would like that aortic valve to go right up against the wall of the aorta during systole, opening up completely. So if we were to say, what is the area, a good aortic valve area, what number would that be? What area would that be?
At the end of, at the beginning of the...
Too complicated. If the area of the aorta is 3, and the area of the LVOT is 3, and we want the aortic valve to open up completely, what should the aortic valve area be? 3. Okay? So again, this is very simple building concept. So if the aortic valve area is 3, if we divide that in half, and the aortic valve area 1.5 becomes stenotic. 1.5 is moderate AS. If we divide it into thirds, at 1, we get severe. And if it's less than 1, it's critical. Simple enough?
Yeah.
So the surgeons who have a wall of an aorta, like this, are putting in a secondary ring on the inside, and now that diameter is smaller.
Right.
So a prosthesis fits on the inside. I now have a smaller diameter. At the very best, aortic valves that are replaced are going to have some degree of stenosis because the area is smaller. Make sense?
Yeah, makes sense.
Okay, now, from a procedural perspective, a burner, you did the aortic valve replacement?
Yeah.
Okay, so when you have an LVOT, which is a uniform tube all the way up to the ascending aorta through the aortic valve, when they take out the aortic valve, what do? The old one.
They detect the liquid and then stick in the replacement valve.
Way too complicated for me. They take out what's in there. They sell it out, right?
Yeah.
So now I have a tube that is completely hollow. Correct?
Yeah.
So if we go back to, there was one who was describing the characteristics of the aortic valve pre-op. Whatever was there is gone. It's removed. So the only thing that's left is a hollow tube, and the hollow tube will have a diameter, and that diameter is going to be your is going to be your identifier as to how big a prosthesis you're going to put in.
Yeah.
So you can do all the aortic valve imaging you want and all the analysis you want. If you're not a cardiologist following someone with serial echoes over time for aortic stenosis, it really doesn't matter what you do in terms of aortic valve imaging. Which means all of the literature that you're reading, all of the literature that's in all of the echo textbooks and so on, whether it's for TAVIs or whether it's for aortic valve replacements, is virtually irrelevant because whatever structure you have there is gone the second the surgeons take it out. And all that's left is a diameter. Fair? Everyone got that? Anyone not? Okay. So now, the commonest surgery is aortic valve replacement. And aortic valve replacement is done for one of two reasons. So Miranda, what are the two reasons why you were doing aortic valve replacement?
Probably regurgitation or stenosis.
There you go. Okay, so stenosis occurs, and we're not going to spend time on stenosis, but stenosis occurs when the valve is incapable of opening up to the walls of the aorta such that the opening becomes smaller. We now have a smaller diameter to get through, and therefore, in order to get a stroke volume through that hole, you need to drive blood through it. And that's when you get into concepts of driving pressure and then LVH to accommodate and so on and so forth. And the catchphrase that we hear in anesthesia all the time, it's a fixed cardiac output. Okay? Cardiac output is heart rate times stroke volume. Stroke volume is fixed because there's a limited amount of volume we can pass through this small hole. Correct? The way in which the body compensates for that small hole is, imagine you were breathing through an ET tube. So grab a 7 ET tube, put it in your mouth and try to breathe through it. In order for you to breathe properly, you have to increase your driving pressure through it. Does everyone get that? In order to push the extra volume through. And at the point where you can no longer push the volume through, or you're unable to get enough volume on the exterior or on the aortic side of the arterial side of the aortic valve, that's when you get into symptomatic AS. Let's put that aside for a second. We said that when you do aortic valve opening during systole, it opens, and then during diastole, it closes. And it closes because there's a high pressure in the aorta, and it causes the leaflets or the cusp to fall in itself. Okay? Who's next? Let's go back to Milka. Milka?
Yes.
If you were to have, in order for a valve to remain a unidirectional one-way valve, in particular, to not have retrograde flow or insufficiency flow or regurgitant flow, what did the cusp have to do 100% of the time?
They have to close. We have to have a coaptation between the three cusps or two cusps.
Between the cusps. We'll get to whether it's one cusp, two cusps, three cusps, or four cusps is a different story. But the cusps have to close on one another.
Mm-hmm.
So in this cylinder, where we have these cusps which are suspended, they need to come and seal on one another. If they don't seal on one another and there's a hole, that's the only way, the exclusively only way that we can get regurgitation. Okay? Does that make sense?
Yes.
Okay, so now, everyone grab your mass for a second. Okay? And when you grab your mass, and I want you to look at these as we go through, I'm going to open up a PowerPoint in a second, but let's look at our mass here. Here we have a aortic valve. Okay? So Celine, you're on the screen. Let's just test you for a second. You have your valve, which is pretty good, and you should have a straight line up here and a triangle on the opposite side. See that? I'm trying to get it like that. See the triangle? Perfect. Okay, so Celine, which side is the arterial or the aortic side, and which side is the ventricular side? Which one's that?
This should be this is the ventricular side, and this is the aortic side.
Okay. Who agrees with her? Who disagrees with her? Hold your models up. She's saying that up here is my ventricular side, and here is my arterial side, aortic side. Someone's got a comment for me to move on.
I think it's the opposite.
It's the opposite. And it's the opposite, and it's opposite to how most people think. So who's been to Netter or to an anatomy textbook and seen the aortic valve look like this, opened up? And it's not making any sense. So when you open it up in a textbook, it looks like this, And when you fold it up and close it, it looks like this. And now, all of a sudden, we have a three-dimensional structure with a straight line across the top, which we call the free margin. And we can see in here a triangle, which is a trigone. And we can assess that when we look through, so if everyone looks at the ventricular side and we open up the valve, I can now look through the valve from the ventricular side. And if I'm looking down at the valve, I'll flip it around and I'll look down. So if I'm looking down at the valve, I see this. And when I'm looking up through the valve from the ventricular side, I see this with my trigones. Okay, now, if we go structure, function, anatomy, physiology, if I take two of these pieces at the tops, like it's a sheet on a clothesline, and I pinch up here and I pinch up here, and I suspend it against the wall, perfect, Celine. At what level in the aortic valve are these pieces up here? Where is this? So Juan, Miranda, or Milka, or Felipe answer. Juan, you answer.
Is that the STJ?
That's
Maybe?
exactly it, the STJ. So the STJ is well defined, and it's where these free margin pieces insert. And this STJ over here meets up with this free margin and this free margin, two of them. Okay, so now if this is my STJ, the bottom part, the ventricular part, is called what? One?
The sinus?
No. The inferior portion.
Will be the LVOT.
So the LVOT is going to be down here, and this level is a junction.
Oh, yeah.
It's a connection between the LVOT and the ascending aorta.
Mm-hmm. Yeah.
So typically people will call that the aortic valve annulus,
Right.
which is incorrect, because the annulus is now, what shape is it? It comes up with a triangle, and then it comes down to this nadir, and then it goes to a trigone again. So if I go back to my first thing that I talked about, which is which variable do you care about, which is the diameter, how do you measure the diameter when it's not actually identified? And you can't. So in an environment where you're doing aortic valve repairs, we refer to this part as the VAJ, the ventricular aortic junction. So the inferior border is the VAJ, and the superior border is an STJ. Does that make sense? Now all of a sudden, I have a valve that has depth to it. So what other valve do we know that has depth to it? That you think of with depth? Miranda?
I'm not sure. Maybe the pulmonary. I'm not sure.
Okay, so let's go to the valves that you probably have done the most surgery, most anesthetics for.
Mitral.
Mitral. So let's just go back to the things we know and let's compare one valve to the next. The mitral valve has got, when you talk about a mitral valve repair, let's just go with lists. On a mitral valve repair, you've done a mitral valve repair, I'm sure?
Yeah.
So you've seen like a P2 resection for Barlow's or for P2 prolapse?
Yeah.
Okay, so what they do is they resect the valve and they work on the cusp. And then what do they typically do in addition to working on the cusp, on the leaflets?
They often put a band around the annulus, or
Yes.
suture some of the fissures together,
To where?
or to add to each other, or they put new cords near.
Perfect. Okay, so if we have new cords and we have flow going from the left atrium down to the ventricle, what we've done is we have a ring at the top which stabilizes the proximal portion of the mitral valve, and we have cords and PAP muscles that support the valve on the bottom. So now the mitral valve has got depth to it. Everyone understand that? So we call the mitral valve not a mitral valve, but we call the mitral valve a mitral valve apparatus. Has everyone heard that?
Yes.
Okay. So if there's a mitral valve apparatus, we know that when we do mitral valve repair work, we have to stabilize the proximal part, stabilize the distal part, and repair or correct the anatomy of what's in between. Let's apply that principle over to the aortic valve. When we do an aortic valve replacement, or better yet, when we look at the aortic valve, what part of the aortic valve, if we were to view this as an apparatus, would equate to the mitral valve annulus? Anyone? Okay, Juan, you stay on. You're gonna keep answering for a bit. We're gonna keep you on the hotspot for a bit. So we have the equivalent of the mitral valve annulus on the aortic valve would be what?
That would be the ventricular. How do you call it?
Let's call it the aortic annulus for simplicity. The VAJ or the aortic annulus.
Exactly.
And then we have a distal part, which is our STJ.
Yeah.
And the STJ is a piece of the ascending aorta that is anchored into. The ascending aorta itself is pretty thick and rigid, so it's an anchoring point. And now we have the aortic cusps that are suspended between the VAJ and the STJ. Does that make sense?
It does. Yeah.
Okay. So let's go through to, let's look at our aortic valve for a second. And let's just take two cusps and let's close it. Let's close the valve itself and see it like this. And this should look like what view in TE that you're familiar with?
That should be the aortic valve short axis view.
So this is the aortic valve short axis view. And we see that our cusp, hang on one second. Mike, I don't want to hear a word out of you. No sounds. Okay. So this is the short axis. And if I were to turn it sideways, it would be our long axis. And our long axis now shows an inferior border and a superior border. Does that make sense to everybody?
Yes.
Yeah.
When you do your short axis of aortic valve, and we're slicing it, where in the aortic valve, who did an echo today? Let's ask this. Juan, did you do an echo today?
No, I didn't.
Who did an echo today? Whoever did, speak up, and you're going to be the one on the hotspot.
Half our ORs are closed, Ben, so no one's going to come up.
Okay, perfect. So if we cut this in short axis, my question to all of you is, where in the depth of the aortic valve did you cut? Did you cut here on the aortic side, in the middle, or inferiorly towards the VAJ? For those who've done echoes, imagine getting a short axis, so a mid-esophageal 45-degree view with your screen, with your valve in the middle of the screen, and now advance your probe, advance your probe, advance your probe, and go through the valve into the LVOT until it disappears. We've now moved in a handful of centimeters. Is that correct?
Yes.
So when we did that, at what point did we make our analysis of the short axis of the aortic valve? And the answer is we have no idea, because no one cares. And the reason why no one cares is because as soon as you start your aortic valve surgical intervention, this is thrown out the window and I'm left with a tube. And all that matters is my diameter. When we're doing aortic valve repair, we have to assess this valve as a three-dimensional structure. And if you don't think of the aortic valve as a three-dimensional structure with a in this case, a width, a length, and a depth, you miss out on a ton of the aortic valve apparatus. Okay? So with that, I'm just going to open up a presentation and we'll go through a couple of slides. Can everyone see this? Can everyone see this?
Yep.
Yeah, we can see it.
Yeah.
Let me just, I'm just going to leave it here. This is a, for those who are familiar, again, I'm going to bring us back to the things we know, which is our mitral valve work. If you talk about mitral valve disease, it's been classified into type 1, type 2, and type 3. Aortic valve has done the exact same thing, same classification system. And identifying why the aortic valve cusp don't coapt is key. And once you understand why or how the mechanism of failure to coaptation happens, then the surgical repair techniques come into play. So let's take a surgical approach. Let's look at 1A. And everyone, look at the screen right now. You see my my cursor on 1A?
Yes.
Okay.
I'm sorry, I don't know why I can see your PowerPoint. I can see your presentation.
Does everyone know? Now no one should see it. I stopped sharing it. Uh-oh. Everyone see me again?
Yeah, we are seeing you, but not the
Okay, so
presentation.
here's my, okay, just me now. Here's my aortic valve, and I'm up at the STJ. If I take my STJ here, and everyone grab your model, and let's take our diameter, and let's spread it out like this. Okay? As you spread it out, what happens to my cusp?
Separate us.
They separate. And if they separate, what happens to my ability during diastole to coapt?
Dysfunction.
It becomes dysfunctional. And what happens to the center point?
Doesn't co-opt.
It doesn't coapt. So now I have a hole. Does everyone see that? I have a hole.
Yes.
So if I have a type 1A, where I have a dilation of the ascending aorta, it pulls my STJ away. And when it pulls the STJ away, my cusp become taut. And then the ability to come together becomes impaired. And I now have a hole, which is a failure to coapt, and I get regurgitated volume. So now I have volume coming in through here. Okay? You can imagine that if any type of repair is going to happen to this valve, one of the things that has to happen is that STJ has to go from here and get narrow again. That's a 1A. The next type of aortic valve dilatation is a 1B. So here's my normal diameter. This is a 1A. If I dilate everything right down from the STJ up here and my VAJ at my wrist, everything opens up. And what happens to my valve? Everything opens up. And when everything opens up, my ability to come together is also impaired. So a surgical intervention to fix this has to address the ascending aorta, has to bring that in, and it has to bring in the VAJ. Now, I don't know if you residents and fellows in Toronto know of a surgeon. His name is Tyrone David. So he's one of the founders of aortic valve repair. There are very few people who understand the anatomy of the aorta in this way, the aortic valve in this way, and that are capable of repairing it. So a 1A is this, a 1B is this, and a 1C, which we won't talk about, is this. Now imagine another mechanism for AI is imagine your knuckles are the aortic valve leaflets themselves. And let's say the knuckles come together. Okay, and my knuckles come together, but they're all calcified and not smooth. Now I have a hole. And now I can have regurgitant flow. Another option is take your cusp and make a hole in it. If I have a hole in it from something like endocarditis, I now have a hole. So things like a hole would be repaired by something like a patch. Calcification is very difficult to reestablish smooth communication. So calcification, generally speaking, either involves decalcifying or replacement, and it's not amenable to repair. Or if it's a type 1A, type 1B, or type 1C, it's reestablishing geometry. Does that make sense to everybody?
Yes.
Maybe, maybe not? Okay.
Yeah.
So I'm sharing the screen again. That didn't work.
We saw the screen there a minute ago.
How's that? Okay, so when we look at, why can't I get this? Sharing is pause until you return. Am I shared right now? Do you see the screen?
No, before we had the screen, but right now it's not over there.
Sorry about that, everyone. How about now?
No.
Share it until you return to the shared. Why is that not working? Stop sharing. Now? Now?
No.
Yes.
We see the Mercedes-Benz sign?
Yes.
Yes.
Okay, so now we have to get into, we know how the aortic valve works. We know the aortic valve insufficiency happens when you have failure to coapt. We know that the aortic valve is an apparatus, and we know that we have a VAJ with a cusp in between and then an STJ. So for the first time, perhaps in your teaching, we now have thought of the aortic valve with depth to it. So how do we go from looking at the Mercedes-Benz approach to aortic valve assessment, which is a two-dimensional view of the short axis of the aortic valve and a long axis of the aortic valve, and start thinking it more as a crown-type structure where there's a depth to it. And the approach that we use in Ottawa, which is one that is probably applicable anywhere, is we use the acronym COM. And we look and assess at the aortic valve apparatus from a structural perspective at its cusps, at its annulus, where the AI is coming from, and the mechanism. Essentially, we're looking at anatomy and physiology, or structure and function. From a cusp perspective, we're looking to see why the cusp aren't able to coapt, why there isn't overlap, why there's a problem in a hole that happens. We then look at the annulus. The annulus is the VAJ, the ventricular aortic annulus, as well as the STJ, which is to a certain degree an annulus. And we see, is there anything about the structural support of the aortic valve cusp that are leading to the inability for the cusp to come together and coapt? Then we look at the location. Where is the coaptation issue happening? Is it lateral to the outside of the valve? Is it in the middle? Is the jet centrally directed? Is it posterior directed? Is it anterior directed? And that leads us into mechanism to try to understand why the structure, the abnormal structure, is leading to an abnormal mechanism. And once we do that, then we can really better understand the aortic valve. Okay, now this is a bit of a plug for the work that Chris and I did. Chris, believe it or not, it was 2008 that we started this.
We're getting very old.
I know we're getting old. When I'm just going to do a little history here, 3D echo is, let's say for argument's sake, 10 years old. And 3D echo, the publications out there, including some of the work that Dr. Vegas did in Toronto, always commented on 3D for the aortic valve to be unnecessary and to be relatively useless, with the exception of the ability of identifying proper geometry. So for example, if I go back to what we said at the beginning, which was when you take out the aortic valve, all we care about is the diameter of the tube. the diameter in the area that we bug Celine on of pi r squared would be accurate if the area was in fact a circle. And what 3D echo showed was, more often than not, it wasn't a circle, it was more of an oval. So the geometric assumptions were incorrect, and 3D echo allowed us to do better geometric analysis. But 3D echo was never really used for the purpose of aortic valve repair, because A, very few centers were doing aortic valve repair. Toronto and Ottawa are two exceptions in Canada. The success rate was unknown, and the widespread use of it was unknown. And for the most part, surgeons just don't really care because they're taking out the valve anyway. If you actually use 3D echo allows us to do a whole bunch of things. It allows us to deconstruct the apparatus to be a lot more precise with where we're making our cuts. And what I mean by that is, when we do a long axis view of the aortic valve, here, let's bring up Miranda.
Yeah.
Miranda, if you can see the lower or the inferior cusp on the long axis of the aortic valve is which cusp on a tricuspid valve?
The right.
The right. And the superior cusp up here is which cusp?
It's either the left or the non.
Okay, so you're correct. It's either the left or the non. If we said that the coaptation has to exist between all three cusps, so the non has to co-opt with the left has to co-opt with the right, and the right has to co-opt with the non. In a long axis view, we can see in this picture the right co-opting with either the left or the non, and we don't know which. So how are we supposed to analyze this valve in a comprehensive way if we don't even know what cusp that is? What 3D is able to do, and I would hope that most of you would spend time with Chris, because he's one of the few people who knows how to do this well, is analyzing the aortic valve from a three-dimensional perspective. Because when we go down to 3D, we can take a short axis. Everyone see this? Non-left, right. We know that this is the right. The red plane is now going through the non. Therefore, let's go back to you, Miranda. Where my arrow is right now, which cusp is that?
Sorry, I'm just looking closely at your arrow.
It's the A, it's the lower one, the inferior part of the A.
The inferior part of the A.
The arrow is
Well, it's still the right.
It's still the right.
Sorry, yeah.
But now because I'm in 3D and the red plane is going through here, which cusp is that?
The non.
The non. So all of a sudden, I know with certainty that this long axis cut of the aortic valve is a relationship between the non and the right. And if I made my plane this way, it would be the right and the left. So all of a sudden now I can actually look and get accurate representation or assessment of a very specific coaptation between two of the cusps. Okay? Now, I'd like anyone to tell me, if we're looking at the relationship between three cusps, so we have the non and the right, the right and the left, those we can see easily. Which two-dimensional image shows us the relationship between the non and the left? Anyone? Well, the answer is you can't. So the limitation of two-dimensional imaging is you can never get a relationship between the non and the left. And if you can't get a relationship between the non and the left, how is it possible to do a three-dimensional analysis of a three-dimensional structure which is suspended in a high-pressure system in the ascending aorta? And the answer is you can't. However, necessity is the mother of invention. If there's no need for it because the valve is coming out, no one cares. when you go back 10 years ago, when Chris and I were starting our academic careers, our failed academic careers, we had a chance to do aortic valve repairs along with 3D imaging. And with 3D imaging, when you have a data set, you can actually make your cut planes anywhere you want, and you can actually cut between the non and the left. And with that, you can now analyze the relationship of the two cusps that come together. And what we did was, using 3D geometry, we were able to measure this area. And we'll leave that for another day, but there has to be a coaptation surface area. The cusps have to fall on each other. And if you have your mask with you right now, bring cusps together and see your overlap. Okay? And in fact, I'm going to stop this for a second. Go back here. You guys can see me now? Yes? No?
No, we still see your presentation.
Okay, hang on.
We can see you if we click on your.
See me now?
Yeah.
So now, if you want to take that presentation diagram and let's apply it to something that's in your hand, if I take my cusp here and I make a box across here and here, or if I take my fingers and squeeze, I now have an overlap of coaptation surface area. Does everyone see that? Does anyone not see that? And if you don't have a model, that's unfortunate because it's a great way to do it. I suggest you do it tomorrow.
Can you do it again, please?
Okay? So with the model now, we can see, let's say 3 of my fingers overlap as part of my area. If I dilate out, I now may only have 2 fingers. And if I dilate even more, I may have 1 finger. So I lose my coaptation surface area reserve. Who just said, oh, someone just got something? That was an aha moment.
Me. Sorry.
Who's me?
Celine.
Celine. So that's key. That means you're playing with the model and you're understanding it. Okay, so now, if everything is symmetric and everything dilates out together symmetrically, then I should have a jet that goes right down the middle. If I don't have something symmetric, so let's take our valve again, and let's just say that this cusp over here now prolapses down. See the prolapse? Trying to get a good angle there. It prolapses down. So now when I look down the chute, I now have, instead of something going right down the middle, it's now going with a prolapse, it's going in an eccentric way. So then you need a transplant. Okay, so it goes into an eccentric way. And that cusp movement is going to affect how the regurgitant flow is going to go. So if the cusps are together like this, and they come together and I overlap with a couple of fingers, if I dilate out, it goes 2 fingers and then 1 finger. But if I drop a cusp down, I now have flow this way. Does that make sense? Okay, so I'm going to load up some echoes now. And we will do some analysis, okay? Is that okay?
Sounds good.
Okay. So those are all the basic principles, except for one more thing. I'm just going to go back to one more thing. When you do a repair, when you look at the markers for success of repair are failure to have recurrent aortic regurgitation in the future. So if we look at our mechanical valves, we know a mechanical valve will last X number of years, 15 or 20 years, before it degrades and needs to be replaced again. A bioprosthetic valve, 10, 15 years, depending what you have. A aortic valve repair at the very least, you want to demonstrate non-inferiority when compared to prosthetic valves and improved complications. So aortic valve repair does not need anticoagulation. So complications associated with Coumadin or NOACs are non-existent. Aortic valve repair is less likely to have infective or endocarditis issues afterwards. So that is beneficial to it. And you don't have a foreign body inside of you, and you don't create stenosis necessarily with it. So if you have the biological benefits of an aortic valve repair, same as the mitral valve repair, and you can demonstrate that the longevity or the durability of the valve is at least equal to a prosthetic valve, then there becomes clear benefit to aortic valve repair if it's done properly. So the ability to assess whether an aortic valve does well long-term are things that we look at in the post-bypass period to look for the markers of successful or long-term aortic valve repair success. And at the very simple way to look at it is, have you restored coaptation? And have you restored a reserve of coaptation? The more coaptation you have, the better the valve will be. Does that make sense?
Yep.
Yes, that makes sense. Okay, so let me just load up some. It's a bicuspid valve. Sorry, I gotta find a better one for you guys. Okay, I'm gonna try to share the screen, okay?
We can see it.
Okay, so who wants, this is not a great one. You can see, if I open up, can you see what I'm doing now?
Yep.
Yep.
Like moving between slides?
Yeah, you're in your computer looking for.
We see your Explorer.
Perfect. Do you see this one now?
No.
No?
No.
Shit. Ah. Okay, so that, sorry everyone, it's the sharing is problematic. Let me okay, can everyone see this one?
Yes.
Yes? Okay, so let's grab one. Let's look at this image. Can you tell me what you see?
So this is a mid-esophageal aortic valve shared axis view. We can see there's no coaptation of the aortic valve cusps, and we can see maybe a calcification in one of the cusps.
Okay, so let's go a little bit slower than that.
Okay.
'Cause I'm not sure. I haven't looked at these in years, so let's do this sort of systematically together. So this is a mid-esophageal short axis view of the aortic valve. It is a tricuspid valve. And I'm not sure where in the valve I'm cutting. Am I cutting closer to the STJ? Can you see my mouse also, my cursor?
Yeah, I do.
Yeah.
Or no? So we see this little nub in here, which is our STJ. Our STJ is here, and our STJ is here. But I can also see, if I slow this down, oh, that was a mistake. I also see that up here on the lateral aspect, I'm not sure if my two cusps come together. So I don't know if I'm higher up closer to the STJ, but more likely I'm closer
Hey,
down
Ben.
towards the, yeah,
Are you playing video or is it still image?
it's a video.
Yeah, it's a still image on our screen.
Oh, shoot. Let me try it again. How about now?
A still image.
Shoot. So the video, so Teams isn't letting me do a video.
Are you
Okay.
sure in the video or sure in the Explorer? I think that's the issue.
It's very possible. It's going to be hard to flip between all of these, eh? Okay, how about now? How about now?
Yeah,
Yeah.
video.
Okay. Okay, Chris, I understand what I have to do. Sorry, well, it's gonna make it difficult to go through a lot of images, but let me just show you some of the things that come up on this screen. This looks like a fairly normal valve, correct? Most people wouldn't think twice about it.
Yeah, seems 3 leaflet.
3 leaflet, looks like it's opening, things are mobile. It looks like it's moving okay. It's not your typical aortic stenosis one. Does anyone, if you look at the cusps themselves, let's go through them one by one. If you look at the non-coronary cusp, I'm going to tell you the looks fairly normal, and the left coronary cusp looks fairly normal. And the one that doesn't look the same as the other is the right coronary cusp. Can someone tell me what they may see on the right coronary cusp that is different than the non on the left? Milka, or Abarna, or Felipe? And you may or may not see it. And the reason why I want to mention it is because these are the subtleties that you're going to, if you're doing aortic valve repairs, you have to start looking for.
There's sort of a segment or something that flicks in and out of view. I don't know if that's just a flat segment.
That's exactly it. There's something that's flicking in and out. So on the free margin, so if you have your model in front of you, if you hold your STJs together, the free margin, there's something on that free margin in the middle that is flicking. It's right there. And what that is most likely is what's called a right coronary cusp bend, and it's going to flip down. So imagine now you take your cusp and it flips down into the LVOT. When during diastole your aorta is pressurized and the cusp come together, that little distal part of the free margin of the right, where that band is, now prolapses down or bends down into the LVOT. If that happens, Miranda, what happens to our coaptation at that point?
It's probably going to be disrupted.
It's going to be disrupted, and now you're going to have flow of aortic blood through the aortic valve apparatus back into the LVOT. Which direction do you think it would go? Central or eccentric?
So if it's a right coronary prolapse, you would probably go more towards the anterior mitral leaflet.
That's correct. So an eccentric leaflet. So if we apply the CALM acronym, the cusp appears abnormal. The annulus we haven't gotten yet. The location is on the free margin central. And the mechanism is that anterior, or in this case, it'll be a posterior directed jet. The right coronary cusp is an anterior structure, and it's going to go posterior towards the anterior mitral leaflet. Okay? Now, the other thing that if you look at this, if we were to measure the sinus of Valsalva here, the sinus of Valsalva, does anyone assume it looks normal, big, or small? And the hint would be, if we look on the side of the image, each one of these is a centimeter. So we're probably looking at 1, 2, 3, 3.5 centimeters in our sinus of Valsalva. Normal, big, small. Normal to big would be the answer. And the reason why is, what did we say the normal diameter was of a VAJ or an aorta?
3.
2 to 3. 2. And this one's 3. And we know the sinus of Valsalva is a little bit bigger than the annulus because it's a sinus. So this is either normal or slightly on the big side. And I go back to that because tomorrow, after I've done this talk, the tools that you should be looking at, you should be looking at the aortic valve from a very simple building block perspective of looking at the annulus and say, hey, the number is 2, 22, 24, 25 millimeters, and this is now part of an apparatus. It's giving you the building blocks to do it on your own. So if I close this, and I stop that, and I go back to this, and I go long axis, and I go here, and I go, oh shit, wrong one, sorry. This is very difficult to do on Teams, I'm sorry. Okay, so now we're into the long axis. Does everyone see that?
Yes.
Okay, so in the long axis, let's just go back to Miranda so we can continue. In this case, we have leaflet, which is our right. What's this one? Posterior leaflet. And is that our non or our left? Do we know?
Not yet.
Not yet. And if we start looking at this, let's start looking at our aortic valve apparatus from this level. Can you see my mouse?
Yes.
So my mouse is roughly at the VAJ, or the inferior border of the apparatus. This is our STJ, which is the superior border of our apparatus. And if you were to take your mask model and flip it on its side, you can now overlay it on your screen and see how this is opening and closing. Now, we can measure this, but ballpark gut feeling, Miranda, is our annulus, our aortic valve annulus, normal, big, or small?
Looks pretty normal.
Normal. Let's just see. We have 1, 2, 3, 4. We're probably looking at 1, 2, close to 3 centimeters for a VAJ. Have you seen someone put in a 30 valve yet?
Not commonly.
The biggest one you've seen is probably a what?
Probably 29, I think.
29, which is rare, and when they're big, they're 27s. So the VAJ is on the bigger side. Our STJ, there is an angle there, but it's a little bit blunted. And if we were to measure it, it's also over 30. And we have cusp issues that it does not look like a typical cusp. Is that fair?
Yeah.
Okay, so if we take our CALM acronym and we again look at our cusps, so our right cusp, if we correlate that to the short axis, the right cusp appears to be coapting or bending below or towards the LVOT when compared to the posterior cusp. Does that make sense?
Yeah.
If anyone's not following me, please ask me to stop. In addition, if you look at the anterior cusp, which is the right, and you look just underneath it, you can see something flickering. You see the flickering? There. There. Can you see that, Miranda?
Yes.
So something flickering on the free margin of the right cusp is abnormal, correct?
Yes.
So if I have the anterior cusp prolapsing below the posterior cusp, you can almost see it in 2D here, this black line in between the front and the back. That's our hole where there's failure to coapt. If we have high pressure on the aortic side, and it now goes through the hole to the low pressure LVOT side, I would expect the flow to be from anterior to posterior towards my anterior mitral leaflet. Okay? Now, bonus points. If there was significant posterior directed flow that was hitting the anterior mitral valve leaflet, what might I see on 2D that would suggest suggest that I in fact have that regurgitant flow in that direction? And I don't see it here.
You might see some fluttering of the
Exactly.
mitral valve leaflet.
Exactly. So fluttering. So let's go confirm this. This is our two-dimensional stuff we have now. If we go through our and Chris will can give you some papers where you look at this. There are only 2 or 3 papers on aortic valve repair in terms of classification. But this would be a dilated VAJ, a dilated STJ, which is a type 1B, along with cusp issues. In particular, the right coronary cusp is at least prolapsing below the posterior cusp. So this is the same image, but now with color. Sorry for the cautery. But do you see now? Our jet. Does everyone see that? Yes, no?
Yep.
So there's our posterior jet. And again, it's not that we need to know how to do something here, but how to, in particular for this case, but how did we use the approach? We knew what was normal. We looked at a VAJ. We looked at a sinus. We looked at an STJ. We know the basic physiology. We know the basic anatomy. And we can see that the right cusp was prolapsing below, and now we have a mechanism. So if you were to assume how are we going to fix this from a repair perspective, you got to correct the anatomy. There has to be a narrowing or a decrease in the diameter of the VAJ. There has to be a decrease in the diameter of the STJ. And the right coronary cusp, which was prolapsing, has to be tightened up and made symmetric so it doesn't prolapse anymore. Can anyone name an operation that they may or may not have seen this year that addresses all of that?
Does it start
Anyone?
with D?
Starts with D. In Toronto, it starts with D. In Ottawa, it starts with a V.
David surgery?
The David surgery. So Dr. David has made many iterations of this. If I'm not mistaken, he's on his 5th. If you go to the States, they'll call it the D5 with a very American accent, but it's the David 5 procedure. In Ottawa, we call it a valve-sparing aortic root procedure. But this is an example of an eccentric jet from a prolapse right. Okay. I just want to. I'm gonna sort of stop in a second, but I just want to load up a couple of a video. I just gotta find it. I'm sorry. Where is it? Cletus. Sorry, I can't find it right now. Give me 2 seconds. I just want to load up one more thing and then I'll stop there. It's not playing. Do you see my my screen now?
Yep.
Okay, so sorry, the videos aren't working. I don't have the codec for it, but you can. I'll just give you an example of how we would go about assessing this valve, and then I'm going to stop, and if there are any questions, we'll go from there. This is a short axis view of the aortic valve, and you can see that that if you have your model and you spread your free margins apart, it's almost as though these are under tension, and when they're under tension, not surprisingly, we get a central aortic valve jet, AI jet. Can everyone see that? Yes? Yes.
Yes.
Okay. In the long axis view, I have a normal VAJ, a large STJ, a large sinus of Valsalva, a blunted STJ, and normal looking cusp. But I have a posterior directed jet. This is the type of information that we're assessing on a regular basis, always in that same order. If we bring it into 3D, you can see up here on this screen, one line here, which is the free margin, and then this band on the top, which is the second flipping thing that Miranda was talking about before. So again, a comprehensive assessment. I wish that I could do echoes upon echoes upon echoes where we can analyze and apply this, but we can't do it over Teams. So I'm going to stop there and say the take-home points. The take-home points with what I was hoping to get across today was, let me close this and get me back on. Do you see me now?
Yes.
Fortunately, yeah.
Okay. So the take-home points that can be passed on during Teams are, what is normal structure of the aortic valve apparatus, starting at the LVOT, going through the valve into the ascending aorta? What are the what's the basic, very basic physiology of aortic insufficiency, which is high pressure in the aorta, causing flow retrograde through the aortic valve because of failure to coapt? The necessary analysis of an aortic valve apparatus involves analyzing the cusp for their structure, their location, and their relationship with associated cusp. The annulus, starting from the VAJ and the STJ and everything in between. The location of where the aortic insufficiency is coming from, and the mechanism in which it's happening. Understanding the aortic valve from a three-dimensional perspective and using the model is exceptionally beneficial. Analyzing the valve in a three-dimensional way using three-dimensional echo is additive to your understanding. Any surgical approach to aortic valve insufficiency has to restore a coaptation surface area. And the ability to assess intraoperatively from a three-dimensional perspective becomes essential. And then if you have those skill sets and those tools and you apply them, then you'll have a better understanding of the aortic valve. If I were sitting in Toronto right now, I would load up tons of images and we can spend the next hours analyzing all of them to understand how it works, but it's not appropriate for a Teams environment. So I'm going to stop there and address any questions. None. So we'll leave it at that then.
Well, thank you, Ben, for the amazing talk today. I really enjoyed it. And was quite informative for our fellows. So again, thank you very much, and hopefully I'll see you in the near future.
Excellent. Thank you guys very much.
Thank you. That was great.
Bye.
Thank you so much.
Thank you.
Thank you.
Thank you.
Thanks a lot, Ben. Is Ben offline, I guess? Maybe it's over.